Alright, so in the diagnosis of an MI, you're going to use this no matter what. Necrotic myocytes leak intracellular molecules such as troponin T, troponin I, troponin C that are part of this sarcomere complex seen here in this image. Now, don't forget that we leak out everything. This means that we also leak out lactate dehydrogenase and creatine kinase and B. So this is the point where you need to really listen up and focus in. The most important markers you need to know are the proteins that are specific for the heart. Which are these? Troponin I, troponin T. The type of troponin I in cardiac tissue is completely different from the troponin I in skeletal muscle. After there's ischemia, it takes a while for the intracellular contents to actually leak from the cells. This is why the electrocardiogram is the gold standard for the first 6 hours. Now, watch out for ST elevation or depression, peaked or inverted T waves, a new left bundle branch block, pathologic Q waves, or poor R wave progression. I previously included the electrophysiology behind these findings, but it takes way too long and it's not worth your time. Most of these questions will describe some of these findings or show you something very simple, such as ST, depression, or elevation. Now, troponin I will be elevated after 4 hours, and it sticks around for approximately 7 to 10 days. So here's our image. Now, troponin I peaks around 2 to 4 hours, usually 4. It is highly sensitive and specific. This means that you won't have any false negatives or false positives. Now what about this guy, CKMB? So the MB part just tells us about the two components, which are M and B. All tissues need creatine kinase. The combination of an M or B helps us figure out where it came from. For example, CKBB is a homodimer found in the brain. Unfortunately for us, CKMB is not unique to cardiac muscle. It is also present in skeletal muscle. So checking for this marker is highly non-specific, meaning that we have a high probability of false positives. So CKMB also begins to rise within this 2 to 4 hour period because it was also liberated from within the myocytes at the same time as the troponins. But it peaks much later, at 24 hours, with a pretty serious drop around 48 to 72 hours. It's almost gone. This means that in the early onset of someone having chest pain, you're going to pull both of these markers out of the person's blood. If they really suffered an MI, both of these markers are going to be elevated. So why do we care about CKMB if troponin I is more specific than any other protein marker? The only useful thing about CKMB is that you can confirm someone had an MI and also use it to determine if the patient had another MI since they were admitted to the hospital. If you see a peak of CKMB again after 48 hours, you need to be really careful and suspect that your patient may have suffered another MI. Why can't we check troponin I? Look at the graph. Troponin I plateaus. It stays rather elevated. Remember, 7 to 10 days, right? Because this cardiac marker stays elevated for up to 10 days, it takes much longer to eliminate troponin I from the circulation. All right, let's keep going. During what period of time after a myocardial infarction is there the greatest risk for ventricular pseudoaneurysm formation? So you have to remember the time frame for both pseudoaneurysm and a true aneurysm. Remember, they are completely different in time and structure. A pseudoaneurysm forms when the infarction takes out a large part of the wall and the only thing left is one layer of fibrous adhesions of the pericardium holding in all of that blood. On the other hand, a true aneurysm is dilation of scar tissue after everything has healed. This is all 3 layers of scarred cardiac wall tissue. And this occurs much later on in the post-MI period. So the answer is 3 to 14 days after myocardial infarction for pseudoaneurysm, and after 2 weeks for a true aneurysm. Now we move on to types of infarcts. Let's visualize the layers of the heart wall. So the coronary arteries are going to be running here in the visceral epicardial layer. Now, a transmural infarct occurs from the occlusion of the coronary arteries before the branches that are diving deep into the inner layers of the heart wall. This is a problem because there is no blood delivered to the entire heart wall. This is why we call this transmural infarction. There's necrosis of the entire thickness of the wall. This leads to ST elevation, and on your electrocardiogram, look for pathologic Q waves. On the other hand, subendocardial infarcts are usually due to stenosis slowly limiting the blood flow to the area of the heart that is last to receive blood. That is the layer directly underneath the endocardium. So this is the subendocardium. Subendocardium is sandwiched in between the endocardium and the myocardium. Infarcts in the subendocardial layer show up as ST segment depression, not ST segment elevation. So another incredibly important part of the initial workup of performing an electrocardiogram is being able to localize the infarct. Why? Because it's an excellent way for question writers to incorporate the anatomy. So now we move on to localization of a ST elevation MI. So let's do a rough drawing of a cross-section of the chest wall. So this is a rough drawing of the chest wall in an axial section like you would see in a CT scan. Sitting in the middle is the heart with all four chambers, and we have the precordial lead V1, V2, V3, V4, V5, and V6 sitting directly on the person's chest. In general, V1 through V4 are great at picking up the anterior depolarization activity, so any changes in V1 through V4 should make you think about the left anterior descending artery being involved. Now, as you can see in our diagram, V1 and V2 are in rather close proximity to the anterior septum. Now, which coronary artery supplies the anterior 2/3 of the interventricular septum? The septal branches of the LAD. That is why any infarct in the septal perforating branches of the LAD will show up as ST changes in leads V1 and V2. Now V3 and V4 are more towards the anterior apex of the heart, kind of pointing towards this area. So if V1 through V4 are focusing on the anterior wall of the left ventricle, what are V5 and V6 going to be detecting? V5 and V6 are looking at the anterior lateral wall of the left ventricle. That means we're talking about the LAD plus the left circumflex, because these are the two arteries that supply the anterolateral wall. So this is the image from our coronary anatomy at the beginning of the chapter. Let's draw an axis on this image so that we can use it to understand all the leads. So now we've drawn the axis that you see in the ECG directly on this anatomical representation of where all of the arteries are. Let's start with the inferior leads that are sitting below the left ventricle. These are AVF, leads 2, and leads 3. These are not in the horizontal plane directly above the heart like the precordial leads. Leads 2, 3, and AVF are representing what is going on from an inferior view of the heart. They are kind of like a camera sitting on your shoe looking up towards your heart. They tell you a lot about the inferior aspect of the heart. This makes a lot of sense, right? They are looking from way underneath below the heart. Now, which artery supplies the majority of the inferior aspect of the heart? The right coronary artery. It gives off the acute marginal and the posterior descending. So any inferior wall infarct will show up as some abnormality in leads 2, 3, and AVF. Now what about lead 1 and AVL? They both have their sensing electrode way out here on the left side of the patient's body, which means that they are great for examining the lateral wall of the left ventricle. Okay, great. Now let's keep going. We have already discussed a lot of these MI complications. It never hurts to hear some of these one more time. We always need to be worried about arrhythmias because very low oxygen levels disrupts the pumps that are very important in maintaining normal ion concentrations around these cells. So dysfunction of the sodium potassium ATPase can lead to very high levels of extracellular potassium, and this can predispose your risk for arrhythmias. Cardiogenic shock is a rather simple concept. If a large segment of your myocardium dies, you will lose tons of contractility. Your heart cannot pump sufficient blood to the rest of your body, and now you're in a state of shock because all of your organs that want blood are now being hypoperfused, including the coronary arteries that run in the epicardial layer. Now, another concern when there is infarction of muscle tissue in the heart is rupture, particularly papillary muscle or wall rupture. In papillary muscle rupture, we need to look out for a new onset murmur such as mitral regurgitation because we lose the ability to hold on to that mitral valve leaflet if your papillary muscle is necrotic. We can also rupture the IV septum. If your IV septum infarcts, you get a VSD. Now, a feared complication of infarction is the development of an aneurysm or pseudoaneurysm. One more time, how are we going to differentiate the two in a vignette? Time. Here we see again, this is a pseudoaneurysm. Pseudo means false, indicating that this aneurysm does not have every single layer of the myocardial wall like a true aneurysm does. A pseudoaneurysm does not contain endo or myocardium. It is just a balloon-like dilatation of fibrous adhesions holding on. This is bad because that blood that collects within the pseudoaneurysm will be moving very slowly, and it can also predispose you for clot formation. And just like free wall rupture, this can occur at 3 to 14 days post-MI. Remember, huge risk for rupture. Let's compare that to a true ventricular aneurysm. This is a true ventricular aneurysm because it is a transmural fibrotic scar of the ventricular wall that bulges out. Scarred tissue cannot contract the normal myocardium, and over time, this will balloon out. It takes a long time for this healing to complete, which is why you expect this to happen at least 2 weeks or later, even months after an MI. Ventricular free wall rupture occurs usually in the setting of a massive myocardial infarct that causes so much muscle necrosis that the pressure exceeds the capacity of the remaining tissue to prevent rupture. So, what are we worried about with free wall rupture? How about cardiac tamponade? The pressure in that ventricle just blows down the myocardial wall like a wrecking ball. Now, what about 1 to 3 days post-MI? This is when we should be concerned about neutrophils invading the myocardium and potential expansion into the epicardial space, where we can get a fibrinous pericarditis. What happens is that fibrin, associated with inflammation, will coat the 2 layers of the epicardium. When these get close enough to each other, there now starts to be a friction rub. This is what you would expect in fibrinous pericarditis. You can hear this with your stethoscope. Now one more time, extremely high yield. Dressler syndrome. This is an undesired autoimmune response against cardiac antigens. This takes a couple of weeks because your immune system needs time to develop this unwanted immune attack. You have to know this. All right, doing great, guys. Take a break and come on back.